Joanne Jones, registered dental hygienist, also an international speaker on oral cancer. And Joanne, thanks so much for being with us.
Oh, my pleasure, Dr. Milligan.
Now, Joanne's won many awards for her speaking and her presentations, and we can learn so much from her about what we need to do as healthcare professionals for our patients regarding oral cancer. Mm-hmm. So why don't you talk to us a little bit about the prevalence of oral cancer?
Certainly. Well, the prevalence is really changing. The profile of oral cancer is changing, and presently in America, there are approximately 42,000 people diagnosed with oral cancer each year. And out of those, 1 out of 2, or 50%, will not be alive in 5 years' time. So it is a devastating, powerful form of cancer.
Wow, yeah. Well, so what are some, and we need to communicate that with our patients.
Absolutely.
But what are some of the risk factors then that we look for?
Okay, well, some of them, as we know, tobacco, alcohol, and also the combined use of tobacco and alcohol, which is one of the, what you see as one of the youth trends nowadays, is really specific as a risk factor. Sometimes population trends, cultural aspects with smokeless tobacco, immunosuppression, dietary deficiencies. However, the biggest one that is really growing at an escalating rate is the human papillomavirus.
Right. Would you like to tell us a little about that?
Certainly. The human papillomavirus, or referred to as HPV, is actually one of the fastest growing sexually transmitted infections really across the world, but in particular in our North American culture. Mm-hmm. And it is transmitted through intimate contact, be it with lifestyle behaviors, sexual behaviors, between the male and the female, or male to male, female to female as well. Sure. But basically, the virus itself is able to inject its DNA into the nucleus of the cell and replicate itself, and it has a really debilitating effect on tumor suppression. So it's able to grow at a very fast rate in an area that for us as dental professionals is quite difficult to actually detect.
Okay. Talk about that a little bit.
Well, a lot of times the affinity is for lymphoid tissues. Okay. So we're talking about tonsillar area. We're talking about, really, if you think about it, posterior. Okay. Posterior clinical presence. So we're talking about posterior area of the tongue, lateral border but posterior, floor of the mouth, back of the throat, and into the lymphoid tissue, the tonsillar area itself.
So the exam is very important to be very thorough.
Absolutely,
right.
Absolutely.
What are some of the subtle symptoms?
Well, and that's one of the most important things of my messaging to dental professionals is because of the lack of sometimes visual acuity of these posterior areas, it's so important to know what the subtle signs are. And some of those include hoarseness or a change in the voice, change maybe in the swallowing pattern, and one that is characteristic of so many people with a tumor that might be at the posterior base of the tongue is almost feeling like they've got something caught in the back of their throat, where they're continually clearing their throat. Okay. Persistent throat infection that's not responding to antibiotics because it's a virus. Asymmetry in the tonsillar area. So not two large tonsils in the back of the throat, but one area that's really enlarged. And another significant one is with the tongue straight out, having it track to one side because it's restricted in movement at the base of the tongue.
Sure, okay. All right. Tell us about the screening exam.
The screening exam has never been more important. I've always been an advocate for it, but now we're at a point in time where it has never been more important. So I won't say a lengthy exam, but I want to say thorough.
Right, absolutely.
In the area of high risk. So we need to know, what are we looking for in the head and neck that are high risk? So our palpation of our lymph nodes is really significant. The cervical nodes, submandibular, supraclavicular, parotid glands. And then as we go into the intraoral area of the oral cavity, we want to look at the tongue, anterior and posterior floor of the mouth, and get really good a really good look at the posterior wall as well, our critical areas.
Great, and you'll be able to provide us a video of this that we'll also have on the site?
Yes, we're working on that presently,
Okay.
so it should be something that's available within the next 60 days or so.
Wonderful.
Yes,
Great.
yes.
Well, we will have that up for
Great.
sure. So an excellent intraoral, extraoral exam.
Mm-hmm.
What about the adjunctive devices that we have out there now?
Well, I think nobody said it better than the Journal of the American Dental Association. They published this last year, and they said that the COE is not predictive enough of early histopathological changes, and that we really need to look at
The COE, the clinical exam.
Yes,
Okay,
yes,
great.
thank you. The clinical oral examination.
Right.
We really need to first and foremost do a very effective examination of the head and neck and the oral cancer screening. But adjunctive devices are not diagnostic tools. They are screening tools. They help us see what may not have been visible with white light examination. And being everything starts at the basement membrane, and by the time it actually becomes visible is in those later stages. This is our issue.
Mm-hmm.
So my thought process is always, why wouldn't we offer an additional screening device to be able to see more than what we can see with our own eyes?
Absolutely, absolutely. What are some of the devices out there?
There are a number of them. The three primary ones are Velscope by LED Imaging. We also have Oral ID, and we also have Identify. Also salivary diagnostics, salivary screening, I should say, with Oral DNA.
Right.
It's another great product. So all of these can be used in conjunction with our own abilities and clinical skills to help save lives, improve earlier discovery, and really improve the quality of our patients' lives. So I really can't think of being able to do much more for our patients than that.
Absolutely. How debilitating can this be, and how quickly can this go?
It's horrible, and I know it firsthand. I went through it with a family member. It probably was one of the most sobering situations I've ever witnessed, and head and neck radiation is the gift that keeps on giving in a very negative way. And if we can save one person, we have made a tremendous impact on that life.
We just found an adenocarcinoma last month for a
Oh,
patient
wow.
surgically removed.
Yes.
Yeah, so doing okay.
Mm-hmm.
Yeah, right.
Very challenging.
How do you suppose we communicate how do you suggest we communicate with our patients?
About
The need and the frequency and that type of thing.
Yes, well, particularly with this new profile that is sexually transmitted, we're on a kind of touchy ground at that point in time, and it is a little bit more difficult or challenging to communicate this. So we have to be very careful. But we may want to say to our patient that you are in an ideal position for us to be able to do a head and neck examination, which please always say, which includes an oral cancer screening.
Right.
We need to say it out loud.
Right.
So our patients do understand what we're doing. And if they say, well, you know, I don't smoke, I don't drink, so why would I need that?
Right.
Then the easiest response is we now know that the fastest growing profile for oral cancer is not related to smoking and alcohol. It's actually transmitted by a virus.
Right.
And 79 million Americans will have this type of viral infection at some point in their lifetime.
Right.
So we as a practice are dedicated to early discovery, and we can do that examination for you today.
The prevalence of oral cancer, speak to me just briefly about that compared to some of the other better known cancers, more feared cancers out
Yes. Actually, 42,000, as I mentioned earlier,
Right.
approximately are the estimates for 2014. Higher incidence than stomach cancer, liver cancer, ovarian cancer, 3 times the incidence of cervical cancer,
Right.
and 3 times the number of deaths, which your listeners may find surprising.
It exactly surprised me, so I thought the
Yes.
listeners may be surprised
Yes.
as well. What else would you like to tell us before we close?
The last thing I would like to say is be part of the change. And the change is making a difference in earlier discovery, and as a practice, joining me, joining Dr. Milligan, and our efforts to improve survival rates, improve early discovery, and have a tremendous impact on the lives of families of an oral cancer patient.
And how do we get more information?
We get more information through, I'm going to have a number of clinical resources posted on your website.
Great.
And patient education materials so that you can convey the message in a very professional manner.
Joanne, thank you so much
You're most
for all
welcome.
you do and for being with us today.
You're most welcome. Thank you.